Well, that was an interesting discussion about resident work hours. My commentary in Orthopaedics Today for this month of October is on that topic specifically. And the findings are, as you already heard, that there is no evidence that it had a positive effect, and there's a growing body of evidence that it's had a negative effect. And I can also share with you this idea about the change in the fellowships and our experience at Rush, where we have very talented individuals that have the opportunity to train every year, come from very talented programs, is that we have noticed a significant decrease in their technical skill set when they come to our program. And so while the academic side may also be important in what is going on, it's my belief that this concept that Malcolm Gladwell talked about, the fact that you need 10,000 hours to accomplish a skill or a task effectively, especially in sport or with technical abilities, is something that our residents are not getting. They're just not getting the hours. And so while some of them may be doing things that are not academically oriented, we have, I think, even better a representation of academics in our fellowship, but the technical skills are definitely less. So all of that leads to some need for some changes and to think about this differently. And that's really what kind of spurred my topic about leadership. And I've titled it Orthopedic Leadership, but it's leadership in general that I wanted to discuss with you, and ways that we can think about this and think about how you can participate more in your lives. These are my disclosures, which are on the American Academy of Orthopedic Surgery website and will not have any role with my discussion today. What is a leader? Well, there's a lot of different ways to describe leaders, and all of you may have your idea of what is most important to you. And I thought that this quote from John Quincy Adams sort of tells you when you see a leader in a room, and if your actions inspire others to dream more, to learn more, to do more, and become more, you are a leader. And so you recognize who those people are oftentimes by the people around them and what they accomplish under the guidance or mentorship of those leaders. Leaders is someone who knows the way, who goes the way, and shows the way to all of us. Leadership is not about personality. A lot of people think that leadership is something you either have or you don't have, but just like anything else in life, it's not a 0 or 10 on the scale. We all have some ability. It's about behavior, and it's an observable set of skills and abilities. Leaders will model the way. They'll inspire a shared vision, which is very difficult. As we've all heard the term with physicians in general, it's like herding cats, and that's an even greater difficulty when trying to herd orthopedic surgeons. So inspiring a shared vision is a real challenge. We challenge the processes that are in front of us, such as things like ACGME guidelines about resident work hours, when we know, in fact, that they're just not providing the result we look for. We enable others to act, and we encourage us to work from the heart, to have passion. There's two main tasks here as a leader in any field. You want to set a path or a goal or vision for the people that are being led, and you want to motivate them to pursue and eventually achieve that goal. And as Helen Keller said, the only thing worse than being blind is having sight but no vision, no path. So how has leadership evolved over the past century? Until the late 1940s, when it was written about, the belief was that leaders were born. They were not made. They had specific traits of intelligence and extroversion. They were just better than the other people around them. From the late 40s to the late 60s, the belief was that somehow leaders was the way they behaved that really made it matter. So you basically followed them, and you were followed in their shadow. It was a question of style, which could be learned. The leaders were not necessarily born. From the 60s to the 80s, when you look at the writings, it depended on the situation the leaders found themselves in and whether they were truly leaders. So it was thought it was a situational event. Some leaders would be good for some circumstances, but may not have that skill set for others. But since the 1980s, the central idea is that a leader is the person that sets the vision for the group that they're with. They have the charisma to lead that group, and that there's a difference between leading and managing that group, which is very important. What is a charismatic leader? A leader that this qualities represents the values and beliefs that they want the followers to subscribe. They build positive images, express ideas that appeal to the people that are following them. They have very high expectations of themselves and others around them. We all know that if you want to get something done, give it to the person who looks like they're too busy to do any more, because they'll get it done. Set high expectations, and then you want to get that emotional response. We are all much more driven if we feel it in our heart, if we have a passion for what we want to do. And it's important to recognize there's a very big difference between leadership and management. And management is good, it's very important, but leadership is about vision and strategy, where managing is about policies and procedures. Again, important, but different. And the leader has to set the vision for all of these things going forward and keep reevaluating that. And a very simple way of putting this, but makes a lot of sense, that Stephen Covey talked about, is management is efficiency in climbing the ladder of success, but leadership determines whether that ladder is leaning against the right wall. That's what we have the ability to do in our specialty, not only for ourselves and for our colleagues, but for all of medicine if we want. Leaders have character. It's very important that we are trustworthy. John Wooden said, be more concerned with your character than your reputation, because your character is what you really are, while your reputation is merely what other people think about you. And Stephen Covey again talked about a principle-centered leadership, having a purpose. And it starts in the beginning with being trustworthy. Trustworthy to yourself, then trustworthy to those around you, and then helping empower those around you with your managerial skills, and then organizing and aligning the group with your vision, and then helping those people move forward. This is very important for all of us. In today's world, especially with many of our younger colleagues, people think that technology is what's leading us. They think that the new tool, the new instrument, the new set of ways to fix things or listen to music or whatever is what's the leader. But that's really not true. Technology is everywhere. As you see, it's all around the world. The world is clearly flat. It's everywhere. And it could lead you, but it really doesn't. It just helps you manage your life at times. Technology doesn't drive leadership. It really doesn't. What drives leadership is vision, goal, passion, and motivation for change. That's what is the ideas of the leader. And technology supports this change, but we shouldn't be seduced by a new technology or a new idea as being the reason why we are going in that direction. Steve Jobs talked about this. It's in Apple's DNA that technology alone is not enough. It's technology married with liberal arts, married with humanities, that yields us the results that make our hearts sing. And all of the devices that Steve Jobs made and is part of were in his mind long before they became available in our hands. He thought about it, he had a vision, and he created a group that could put that together. In fact, if anything, technology happens to disconnect us in many ways. So think about the technology we see in our lives. We're no longer doctors, we're providers, and there's lots of providers. But in fact, our specialty and our relationship with our patient is one of the most important relationships in all of human existence, because we're caring for people and we're helping them get better, and they trust us with their lives. So we're not providers, we're doctors. When insurance companies look at us, we are under the category of medical losses. That's what they pay us, as medical losses. That's the technology behind their system, where it's not medical losses. They're paying us for the services that we provided for the people that already paid a very significant fund to help these insurance companies do well. And we all know that the CEOs of health insurance companies are the highest paid CEOs in the world. So they're doing just fine. Where do we get these ideas as leaders? These new ideas and innovation, they're all around us. And if you ask the CEOs that run corporations, they'll tell you their business partners help them. Employees, very importantly. So for those of us in academic medicine, our residents, our fellows, our medical students provide us ideas every day that can help us to learn more about our specialty and to learn more about leading. So be careful to pay attention to all the sources that ideas and innovation that come from. And an idea-driven organization, really the number one resource by far is the people. It's not the technology, it's the people. And they come from everywhere. We work better when they connect these ideas together and ultimately lead to more ideas and more outcomes that are favorable. These ideas are often fragile. They'll come to you in a brief moment and then it disappears until someone grasps that idea and moves forward with it, connects it with more ideas, and then it becomes a goal, and then it can become possible. Everything in life is created twice, once in your mind and then in reality. So keep that in mind. And the successful people that innovate, that change, usually create an environment around them where there's the proper culture, there's the proper process, and they have the tools or technology to move forward with that. And that culture is based on trust. People will open their minds and tell you what they think if they trust you. When a medical student is afraid that they may be embarrassed if they give you an idea, they're not going to share an idea. It may be the best idea you've heard in a long time. So you've got to create a sense of trust. You have to create a sense of desire. We all work better if our emotional component of our life is aligned with our mental component, and passion. That's what drives us. And we understand that. And really, we have to keep in mind that we're really happy in a certain environment. And that's when you love what you're doing. And that's when you love what you're doing and you're happy, you're going to be successful. The process that comes about is simple. We realize that these ideas are fragile, as I mentioned. And so we've got to really cradle them, not crush them, and try to see if we can make them grow into a goal and a plan, and then get it to work, get it to stick, and then we finally have solved the issue. And we have the tools that many of us can learn. These are not inherent tools. These are organizational tools for helping with innovation and ideas that we can use. Power tools, which is really the least effective way. We can use informational management tools, but we want to use these leadership tools to inspire those around us to share with us their ideas, because the creativity of a leader is very important. Competition is a game of who can generate the best and greatest number of ideas in our specialty and in any profession. You don't manage creativity, you manage for creativity. You create the environment to it. A creative man is motivated by the desire to achieve, not by the desire to beat others. Physicians and leadership. Physicians, by definition, are leaders. We've been leaders our whole life in every single part and segment of our lives. But not every physician wants this, especially when they get the chance to choose the environment. So as we're trying to get the goal of becoming an orthopedic surgeon, part of the assessment of those around us is this person a leader? First we're in college, then we're in medical school, and further on. And we play that role. But then at some point, many of us will step back and say, I don't want that role anymore. I want to be content with where I'm at. And further all, it's not that easy to continue to be a leader all the time. All of us know how to be a clinician. That's what we do. We're doers. We have good interactions one-on-one with our patients, we hope. We have a reactive philosophy in terms of the way we deal with them. We can decide what needs to be done and move forward and help out our individual patients. But to be a leader requires a broader viewpoint that all of us have the ability to achieve if we want. We can plan and design ideas. We find out oftentimes when we do get involved in a committee or a society that we actually turn out to be the one that has many good ideas that need to be shared and get grasped onto and become the goals of those groups. We have a proactive philosophy in trying to move forward. We can understand what delayed gratification is all about. We've all been there where we've worked so hard for a goal and it's taken forever. We didn't get it, or we finally did get it, but we did what we needed to do. And the value collaboration and identifying with organizations, all of these things are important. And we have some real dynamic physician leadership in our society of orthopedics. And some of that now has blossomed into our leadership for our entire country. So we have a senator and a representative of our Congress who really are helping us and representing us as physicians, us as orthopedic surgeons. So this is important for all of us to keep in mind. And if we don't want to take this path, to support these people and be some of their followers to help them out. Now, my perspectives have been written. I try my best in my Orthopedics Today column where I write a very short commentary. It's no more than 1,500 words, which sometimes is very difficult. But I've been really sort of obsessed a little bit over the last year about how many intelligent, strong people I meet throughout these lectures, presentations, or phone calls about the commentary who could be true leaders but choose not to be leaders. And we need you to step up. It's time in our careers to have those of you that want to lead and can lead to step forward. It's a very critical time for us in all of healthcare. And that was my commentary in January, is that this year and the next few years, there is no greater time than for you to step forward and be a leader, not just in orthopedics, but for healthcare in the United States. You've heard bits and pieces throughout the last day or so about this problem that we have, this small problem we have about healthcare delivery. We're the most expensive healthcare delivery system in the world, and by far the most complex, as you see by this diagram here. 30 trillion of unfunded Medicare obligations. There's no way we can pay the bill for healthcare based on normal financial and economic analysis. Somehow it's got to be figured out. It is the leading driver of national debt for all of us. We have the highest per capita spending of any country in the world, and 2 times higher than the next country. And we're not even in the top 20 in value based on World Health statistics. Something's not right. We're not aligned properly. You can see this in a variety of different ways, and it doesn't take you long to see that anyone recognizes this is a problem. It's not going away. Somebody is going to fix this. Are you going to let someone who's not a physician, who really doesn't care about our role in treating patients, make the decisions on how to fix this problem? Or would you rather have people that are in the trenches like we are try to fix this problem? I know what my answer is. We have to understand we all live somewhat of an entitled or very, we live a good life. We are the highest paid specialty out there. We can take care of our families. We can send our kids to private schools. But the rest of the country is really struggling. Every patient you see is likely to have this issue. It's not every patient, but it's most of them. The average family pays more than $15,000 for employee-sponsored coverage. And if you spend everything you can and your credit cards and everything else, and you still can't pay your bills, the one bill you can't pay is your medical bills. And 3 out of 5 personal bankruptcies are because they can't pay their medical bills. And it's not just the people that are uninsured. It's the insured population too. The burden is overwhelming. And when you look at what constitutes healthcare, you see that we play a huge role. We may only be 3% of all the physicians out there, but 100 million adults have musculoskeletal conditions, about a third of our population, lasting 3 months or longer during the past year, 2 times more than any other medical condition. And yes, primary care physicians, internists, other people are treating this, but we are the leaders of the management of musculoskeletal care, and we have to assume that role. And you can see that this number with our baby boomers is going to go up. Imagine that more than 6% of our gross domestic product is based on the management of musculoskeletal disease, and the number keeps raising. And then imagine that our Congress people say, okay, we've got to figure out how to reduce this cost. And how do we do that? 70% of the orthopedic surgeons who take care of some significant part of this burden are in private practice and receive fees for this, for how many procedures they do and for how many times they are able to code for a certain problem. It's not based on anything other than that. Every time we put a procedure down or a code down, we get paid for it, or we hopefully get paid for it. And it's administered in this fee-for-service system still, even though we know it's all trying to change, and it's not really value-driven. So when you're looking at these economics from the outside in, it doesn't look very good. More than 1 million people will undergo a joint replacement in 2015. It's the most common hospital-based surgery at this time, and it's driven by volume. Our numbers are dramatically higher than anywhere else in the world for total knee replacement. The cost continues to increase, and remarkably, despite all the technology, all the gifts, patient-specific instrumentation, you name it, up to 20% of people are dissatisfied with the result that they have. So we are going to go from a volume-driven healthcare system to a value-driven healthcare system, whether we like it or not, kicking or screaming. That's where we are. Who is going to make those decisions? Do you want someone who's not a physician to make those decisions? Do you want an attorney to make those decisions? Do you want a businessman to make those decisions? Well, that's who's making them now, if you're not involved. So you can kick and scream all you want, but if you're not involved, those are the people that are making your decisions. So I call to you to think about this with your head, your hearts, and your hands. Our hands are gifted. That's why we are where we are. Our thoughts, our passion, our action make a difference. So let's look at some of the things we can do for surgeons as leaders. There is some good literature on this. The thoracic surgery clinics had some really nice work on this, and I would encourage you to look up in this journal if you want to read more about this, but there's more and more things about this. And I want to kind of disperse with the idea of the baby boomers concept of being a leader. Being a leader is just not being a boss, okay? Being a leader is much more than that. And so we have to think about this in this way. A boss drives his men. A leader inspires them. A boss depends on authority. A leader depends on goodwill. A boss evokes fear where a leader radiates love. A boss says I, the leader says we. The boss shows who's wrong. The leader shows what is wrong. The boss knows how it is done. The leader knows how to do it. The boss demands respect. The leader commands respect. So be a leader, not a boss. It's 2015. It's not 1975 anymore. There are a variety of leadership styles, and we all may possess some part of this. And you can break them down into these here. As you see, coercive is to say something like, do what I tell you. But we're getting more and more along the lines of the democratic, what do you think, the pace setting, do what I do now, and then coaching, try this, as ways that are much more effective. And when we look at some of the capabilities that we have in our intellectual, our emotional intelligence, you can see self-awareness is very important. And we are all pretty good at that, actually. That's how we get to where we are in our orthopedic field. Self-management, many of us could do a better job in this area. We sometimes lose that self-management and we act out of character. So you hear about the surgeons in the operating room who misbehave, and yet when they're outside the operating room, it's the nicest person in the world. And that self-management is important as a leader. Social awareness. We have to think outside the box. We have a pretty homogeneous group of individuals that go into orthopedics, and that's not the way the rest of the world is. And we have to work on our social skills, and that oftentimes can be benefited by voluntary care, helping out people, teaching our kids how to give to those who are not as well off as we are in terms of life. So these are important things. And there's really a process, which I won't go through entirely, but there's a process of creating some of these major changes, establishing a sense of urgency. We all know this intuitively, we know. You have to make sure people know, we got to do this now. That's what I tried to do to tell you about this healthcare transformation. Those numbers are very significant. We have an election year coming up. This is a critical time for us. We have to be involved, or we have to accept what other people do for us. There is a sense of urgency here. We have to create a guiding coalition, and there's many parts of orthopedics that are doing their best to do that. We have to develop a vision and a strategy, and that's being done at a variety of levels. Communicate the change, empower a broad-based action among all of us, get some short-term wins along the way. We have to consolidate our gains, take what we have, and keep moving forward. And then we have to keep anchoring new approaches in this culture and keep moving forward. We can't just do this for the next year. It's got to be going forward. What about just in our own personal lives? Well, we heard yesterday that you don't want to be considered the captain of the ship in a malpractice lawsuit, but we are the captain of the ship in our OR. We have the ability to manage the OR, and we do that by leading by example, self-managing, treating others with respect, and doing all the things that you know is the right thing to do. And that's very important in your normal work environment. How about in academics? How does that play a role? Leadership is very important. Here's a bar graph that shows you that if you have someone who's involved in research that's been funded, you're much more likely to get more funding. And if a person's never been funded before, it's unlikely to be funded. So when we look at things academically, we have to keep these in mind. And we see that orthopedic departments at academic success is directly associated with scholarly productivity, which is important for the residents, it's important for where we train, and it's important for us to continue to grow our knowledge base and support these groups that do this. Now, we can ask department chairs, and a lot of us sometimes feel we get dissociated from the academia, but they have a lot of good ideas in certain environments. So here's one where they had department chairs, journal editors, editorial board members complete a survey. And here's what some of the things looked at for life balance. And what you'll see is the number of hours worked, about 70 hours per work, but some of them 110. Does not even fit our residency work hours. So our residents being prepared for this life where they have this, where they step out or hand off patients or hand off cases, I think not for the real world. And then you see a variety of ways that they spend their daily lives in terms of separating in a clinical and otherwise. And then I would draw your attention to the other side. Look at how they manage their own personal lives. Exercise, a fair number of them exercise on a regular basis. They have a primary care physician. They get regular checkups. They eat right most of the time. They don't smoke. They're physically able to do things and feel well through their lives, and they're keeping themselves at a good body weight. This is self-management. This is important. This is part of your example as a leader for your family and the residents and those around you. Highly successful orthopedic surgeons compared with other physicians in general. What you see here, as you've all known, that we are very happy with our choice of our specialty. Most of us love it. Most of us have to walk away from work and tell ourselves it's time to go home because we want to see the next patient or the next case. It's not always like that, but we really do love what we do, and that's borne out in these surveys. And you see, again, exercise and other things are very important. So successful surgeons are often motivated by a desire for personal development, whereas financial gain played little or no role in the decision to take positions of leadership. So this is important. Most respondents were happy with their specialty choice despite the long hours and high levels of stress, and successful surgeons cope with considerable demands despite the clinical, administrative, educational, and research duties while maintaining a high level of health, happiness, and job satisfaction. It's that work-life balance that's so important. In our daily lives, we also have the ability to affect patient safety, both our own patients, but also the patients that are in the hospitals as we work in groups. We have a very important role. Here's a review of 36 articles that showed that the most common causes of preventable surgical harm reported to the Joint Commission, and basically outlines the goals for what we can do as orthopedic surgeons to make sure that we do that. And we know we've all seen this transition. The residents don't even recognize this happened. Things like surgical timeouts, which a lot of people take for granted. But when you get on an airplane every day to fly, aren't you happy that the pilots go through a checklist every day and they don't just have to memorize off the top of their head which instruments are working or not working? That's what we're doing. It's based on the airline industry, which has one of the best safety records out there, that we're doing in the operating room. So don't blow off the surgical timeout, because as you start to do that, then the nurses start to do that, and the residents start to do that, and then all of a sudden, someone gets a left knee replacement instead of a right knee replacement. And that's not a good thing. And that happens more than 100 times per year in the United States. So we have to do a better job. So be the leader and make sure that you keep your patient safety first. And although some of these mundane and difficult things will bother you, you need to lead the whole group and make sure you do that. So we need to facilitate it. We delegate the responsibilities. We need to standardize it, so whether we're tired or someone else is tired, we do not make mistakes. We're all working together for the safety of our patients. And here's the 6 C's of orthopedic surgical safety: communication, consent, checklists, confirmation among the people in the room, concentration, and collection of data to make sure you're doing it well. And if you need to, at times, if you've got to walk out of the room and come back in, that's what you need to do for the safety of your patient. That's a leadership skill. Orthopedic surgeons are the key leaders to ensure safe and optimal patient outcomes in every setting in the operating room. You need to assume that responsibility and be that leader for your patient who's trusting them with their life. Leadership and cost control. Here's another area where we clearly show what we can do. Here's a review of 2 centers that implemented a surgeon-led programs to demonstrate responsibility and technology acquisition, and both of them showed significant reduction in costs. We went through a transition in our group where we were hospital-based operating rooms, and we then purchased our own surgery centers. It's amazing how quickly you pay attention to what you're using in the surgery center, and you realize how much waste goes on and how you can get alignment among people that may have different views based on cost containment alone, not based on decreasing quality of care. We don't tell surgeons that you can only use 2 anchors for an instability because that's all we get on our implant fees. You can use as many as you want, but we don't have to pay $350 per anchor. I mean, these companies that are doing this are getting larger and wealthier every day. They have plenty of room to reduce their costs if you can motivate them to do that. So hospitals, but every part of healthcare needs physicians to be engaged to provide this. We sometimes don't want to do this, like we don't want to make the decision about what implants are being used. Recently, a surgeon at the Cleveland Clinic made the headlines because the Cleveland Clinic, which last year made $1 billion of revenue over their expenses. Now, it's not profit because they're not for profit. You ask them, they didn't get a profit of $1 billion. They're a not-for-profit organization. Well, what do they do with that added revenue? They just reinvest it and build more buildings and build more MRIs and build more ORs and buy more facilities. That's what they do because they're a not-for-profit. And they raise the physician's income by less than 1%. Okay, where did that money come from? So physicians need to be engaged. And that, by the way, is oftentimes held up as the example of the way healthcare should be provided, the Cleveland Clinic, by our government. And I sometimes wonder where their priorities are, despite most of their administrators being physicians. And it's interesting because when they become an administrator, their administrative value goes, their cost and their fees go up. So a cardiothoracic surgeon that runs that institute, and this is public knowledge, and I'm not being critical, but his package every year is about $5 million. That's what his income is, much more than he would make as a cardiothoracic surgeon at his institution. So I think we need to be more involved. There was a discussion yesterday about bundled payments, and I listened to this because it's really important. Again, this is another way we're trying to reduce costs. There's a traditional fee-for-service model that's out there, and then we're going from that where we're paid for each and every thing that we order or prescribe, regardless of the value, regardless of the quality, to where we're going to assume risk with the payment for this, and it's all going to be under one fee. And it was mentioned yesterday that the area where we have the greatest ability to make a difference is on the back end, after they're out of the hospital. And I would really question that, because to me what that sounds like is that you've given up on half of the place where you can really make the biggest difference, which is the hospital. And if you do these operations as an outpatient in a surgery center, you can dramatically reduce this cost like we're doing in Chicago. And so I think that you should not just take the back end. You need to take control of all of it. We're only responsible for 7% of the overall cost, but I can tell you that we probably have had the greatest reduction in reimbursement out of any one of these categories over the last 10 years versus everybody else. So, that's a problem. That's where we need leadership. Cost control is important, and I think with physicians involved, we can do this in a way that's fair and that keeps our patients in a good, healthy state. What about diversity? This is important, especially for, as it was mentioned earlier, us gray hairs, because diversity is kind of a newer concept overall in terms of how this all works, and especially in the field of orthopedics. When you start looking at things versus male versus female, young versus old, role of technology, and recognize that the average orthopedic surgeon practicing in the United States is 54 years old. There's a change coming about, and it has a lot to do with the personality traits of how we were raised. So, of course, many of us are somewhere around that baby boomer age, or a little bit younger, a little bit older, and we had a different way of doing things. Chain of command, work-related was our primary focus, motivated with strong speeches, we hope, and expectation of leadership role, all of that. And now we're training and teaching Generation Y, which is completely different. Completely different. It's a meritocracy, individuals are first. Our residents are much more interested in having a lifestyle that's probably better for them in the long run, better for everyone, but something that we didn't do. They really oftentimes don't listen to these speeches because they feel like they're doing their own thing anyways. And for those of you who have children, have seen this transition and deal with it. I have 5 daughters, so I'm usually the quietest person in the house at all times. And it's the same thing. When my girls get really upset and they say, "Dad, aren't you going to say anything?" And I said, the same letters in the word listen are in the word silent. So I'm listening to you. And so I try to keep them in mind with all that. What about this diversity? Well, we really think about this. It's mandatory for this next generation of our society. We need to teach and have the Generation X and Ys and whatever you want to call them, the millennials, to be educated in managerial skills, but also leadership skills to move forward with what we're doing. And we need to mentor them and help them with that. But this is the diversity we have in orthopedics. We're not really doing so well when you look at all the categories. This is surgery, and as you see here, this is with regards to equality for women, and you see our numbers are very low. This is much different in the rest of the world, where you see in many of the European programs, 1/3 or more of the residents in orthopedic are now women. So it's changed a lot in the rest of the world. We're slowly eking forward, but you see if there's anyone that's going to be accused of a glass ceiling, as you see here, when you look at professors, full professors, we're going to be a target for that if we don't pay attention to this. Percentage of women in leadership in the 5 surgical subspecialties, of course, we're last, and that's been that way for a long time. and there's been very little movement despite what's going on in society. We're going to be targets for that too. We need leaders to change this. It's got to change for all of us. Some of you may say, well, I have my ways and I'm not really that interested in this, but please keep in mind that diversity is critical for the next innovation, the next new ideas. For example, this philosopher stated, China can draw on a talent pool of 1.3, it's 1.5 billion, so 5 times the United States. But the United States can actually draw on a talent pool of 7 billion people, the entire world, and recombine them in a diverse culture that enhances creativity in a way that cannot happen with the ethnic Han nationalism. So diversity enhances creativity and innovation and moves us forward. What about burnout? Again, this goes back to our personal lives and how we kind of deal with this, and there's some work on trying to make sure that this doesn't happen. When you look at the greatest contributing factor to medical errors, which is again a patient safety issue, stress or burnout is one of the highest factors, and we've talked about that in orthopedics today. The way to avoid burnout really is to try to develop a clear personal vision, what's most important for your satisfaction and happiness. And most things in life, again, are created twice. Once in your mind and then in reality. So think about it. The happiest people don't have the best of everything. They just make the best of everything that they have. And that's what you should do. We're all been very blessed, and we should not take that for granted. Here's an example for characteristics of associated factors: absence of burnout with satisfaction of career. So if we're not having this problem in orthopedics, it's fortunate we don't have this problem, but we oftentimes think that we're sort of a little bit protected from this. But as I wrote in one of my commentaries last year on suicide, I was shocked to find out that even in an area of suicide, it's 2 times higher in physicians than the normal population. And even in the field of orthopedics, it happens. It's quietly kind of kept under the rug. But 2 important people last year that I know committed suicide. And they were in their 50s, and they obviously had some concerns about what their value was in life, but it does happen. And so this is really important to keep this in mind, and part of your leadership goals to make sure that you have a personal wellness strategy, cultivating relationships with your family and with those around you, personal reflection activities, whatever that is for you, whether you like to work out, whether you like to play golf, whether you like to read, travel, whatever. Spiritual practice is very important. A lot of people also give that up, but it really is important for us as human beings in terms of our own taking care of ourselves, being well. Self-care, and then hobbies and personal interests, as we talked about. And that can really help you avoid that, especially when you look at what we're doing. We work a lot because we love what we do. It's mostly patient care, but the biggest stressors we have are excessive workload. It seems to be increasing overhead. We have deficits. We have things like ICD-10, which I know many of you are very frustrated that you have to make this transition, but remember, we're the last country in the world to make this transition. ICD-9 has been around for 30 years. ICD-10 has been around for 20 years, and most countries have had it in their system for 10 years or more, and their physicians don't complain anymore, and our residents and the ones following them won't even know the difference. ICD-10 will be their norm. So we have to make these transitions because it's important for world health and for solving that problem about healthcare economics and getting the numbers that we need. So I know it's a pain in the butt, but we have to work through that. What are the warning signs for this? Withdrawal, irritability, and family disagreements. So look at your peers and your partners and try to help them out. Reach out to them if you see this. You can build on the strength of your relationships and see these things actually improve if you're careful. Can leadership be taught? So I've gone over a lot of things and I'm calling you to action here. Can it actually be taught? Well, it can be. And if you look at a survey here that was done in the General Surgery Department of Leadership, there's a variety of different programs that are out there. They can do this by recognizing the gaps in preparation, and then they get together and they create an appetite for self-improvement, and then a program to seek guidance to put this all together. And there's a variety of ways that you can do this, and I don't have time to go into all of that, but it can be taught. It's a learned skill. It's not inherent or intrinsic to each individual. It can be learned. And that's been recognized by the American Academy of Orthopedic Surgery, and they have an effectiveness of their leadership program publication already. And when you look at what they did when they took these areas of leadership competency and they applied it to a number of talented individuals, what they saw is those people that went through this definitely showed leadership. Higher academic rank than others in their peer group, their control group, department or specialty chief of national committees. And these are the people that help guide and lead our various programs and societies. Here's another which just looks at that, and again, the academic rank is higher, their subspecialties or more, and chair these national conferences. So leadership can be taught. It's important to look at this, and it's important to support these programs. And if you want to be a leader, there are programs at the American Academy of Orthopedic Surgery, American Orthopaedic Association, that provide you with these opportunities to go to these places, learn about this, get involved, and become the leader that you really can be. Here's another one that's just looked at faculty development and showed, again, despite a heterogeneous group of studies, leadership development activities universally valued by participants. And so those that got involved really valued what was going on. And we have another article here by AOA talking about the critical issues in front of us. Here's a very nice article in the Journal of Vascular Surgery. Talent management and physician leadership. Training is essential for preparing tomorrow's physician leaders. It really is something that, if you're interested in, there's a lot of various aspects of this that are important. So my take-home points for all of you is this. Leadership is important for the things we do right in our own backyard. Patient safety, good outcomes, preventing burnout, and getting happiness. Leadership is primarily about setting a vision and motivating people who want to achieve that shared vision. Communicating the vision, building trust, empowering people, and working in teams are all critical, and we all know how to do this. Leadership and management are definitely different, and it's important that we have leaders so we know that that ladder is on the right building when we get to the top. Leadership is teachable, although not everyone can be taught or is interested in that. And you have to have the courage about this. Remember Michael Jordan's comment, I missed more than 9,000 shots in my career, lost almost 300 games, 26 times I've been trusted to take the winning shot and I missed. I failed over and over again in my life, and that's why I succeed. And Steve Jobs also said this with a final comment with technology. He says, your time is limited, so don't waste it living someone else's life. And for that matter, don't waste it letting other people tell you how you should live your life and complaining about it and not doing anything about it. Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice. And most important, have the courage to follow your heart and your intuition. They somehow already know what you truly want to become. Everything else is secondary. So I would urge all of you to keep these thoughts in mind, recognize your abilities to be leaders, and recognize there's a sense of urgency at this time in our lives and our careers for us to be able to practice, to be the physicians that we want and the people that we want in the next decade or more. We all have to do as much as we can to be the leaders that we can be. Thank you very much.